Hi, and welcome to Policy Unpacks, a podcast by Global Policy Network. In this series, we dive into the policies shaping our world, from healthcare to sustainability to education, and explore how these critical areas intersect to drive meaningful change. Whether you're a policymaker, practitioner, or just policy curious, we're glad you're here. Let's unpack policy together. My name is Amina Sachi. I'm the founder and CEO of Global Policy Network. And today's episode, we will be taking you through our new policy report, Closing the Gap in Cow's Milk Protein Allergy, CMPA, Prevention, Timely Diagnosis, and Equitable Access to Care. This is the accumulation of insights from our roundtable, which took place on the 13th of March of the same name. So I'm absolutely delighted to be joined by Nick Makwana, who's a consultant paediatrician at Sandwell and West Birmingham Hospitals, who kindly chaired the roundtable and was instrumental in writing the policy report. And also Christian White, who's policy and influencing officer at Allergy UK, the UK's leading national charity supporting people living with allergies, food hypersensitivities and intolerances, and Anne Biggs, Deputy Head Clinical Services, also at Allergy UK. So welcome everyone. Thank you for joining me today.
Pleasure to be here.
Thank you very much.
Nice to be here, yeah, glad to be here as well.
So let's jump into why this report matters. So to start us off, let's set the scene and talk about why CMPA matters. So Nick, can you explain to us clinically why CMPA is important and why it matters for families?
So cow's milk protein allergy affects about depending on what you read, 3 to 5% of children in the UK, making it one of the most common food allergies in young children. And it's basically a reaction to ingestion of milk, an immune reaction to ingestion of milk, which is basically of two types. So you can get what we call IgE-mediated allergy, which is the one that most people typically associate it with allergic type symptoms. So this is sort of lip swelling, eye swelling, hives, and obviously this can lead to anaphylaxis, so including tongue swelling, breathing difficulty, wheezing, going very pale or passing out. And this type of allergy is sort of well understood. We have good tests for this kind of allergy, and we can make plans based on that. There's also something called non-IgE or delayed type allergy. And this sort of occurs after ingestion of a food, but 2 to 24, even 48 hours later. And this sort of it can affect the skin or the gut. So particularly children with eczema might get an eczema flare, 6-7 hours after ingesting some with milk in it. They may get tummy symptoms between sort of loose diarrhea type stools or constipation or even sort of fresh blood in the stools. And what's so important about cow's milk protein allergy is not just a feeding issue. It's hopefully from what I've said you can realize it's an immune response that actually affects multiple systems, so the gut, the skin, and the chest. And in babies certainly it can present in quite subtle ways, and for families that matters because it sits right at the start of life. So this is when feeding, growth, sleep, bonding are all happening at the same time. So if a baby's unsettled, not feeding well, not thriving, not sleeping, it affects the whole family dynamic quite quickly. So I think it's sort of one of the earliest signals in a child's allergy journey, and getting sort of the diagnosis and management right at that early point can really change the trajectory for that child. So it's not just about milk, it's about early life health, I suppose is how I look at it.
Thank you. And Christian, from a policy perspective, why is CMP such an important issue, especially in the context of the NHS 10-year plan and its prevention agenda?
So cow's milk protein allergy sits at the intersection of early diagnosis, prevention, the reduction of health inequality, and improving child health outcomes, which we know are at the centre of the government's 10-year plan. But it's more than that as well. We know that from research conducted by allergy clinicians and published in the British Medical Journal in 2021, cow's milk protein allergy causes a quarter of deaths in children. It's the single most common cause of fatal anaphylaxis in children and young people. And from a political perspective, it's a sign of failings in our system. It's more prevalent in the UK than anywhere else in Europe. It goes beyond this as well. You don't just have to have the allergy yourself to suffer. And we find that parents of children with food allergies reported being more stressed, anxious, and more depressed than parents of children without a food allergy. So this ties as well into the government's focus on mental health and the costs of mental health. At the heart of the 10-year health plan for England is a fundamental shift from treating illness after it occurs to preventing ill health before it develops or worsens. Tackling cow's milk protein allergy involves improving access to healthcare, targeting support where it's needed, and reducing disparities in outcomes between different populations and regions, which are all strong themes throughout the 10-year health plan. It really goes to the heart of the government's current agenda.
Thank you, Christian. And from a service point of view, Anne, when did CMPA first come into your radar as something that needed change?
It came on my radar the minute I started working in community services. 17 years ago, I started working as a children's community nurse, and that was, it immediately came on my radar the minute I joined community services. It was a really interesting space. It was 17 years ago. I worked across two large London boroughs. And if you were a child or an infant in one London borough, you would be able to access a specialist health visitor who was specialised in managing allergies. There was a well-established community allergy service with a dietitian, and there was a secondary care allergy service that was connected to the community one. They sat in the same office. And if you lived in that borough as a community nurse, it was very easy and straightforward to manage when you suspected milk allergy, either because the parents, you were seeing severe eczema, there was multiple A&E attendances. The other borough was really challenging. There was no specialist allergy service, there was no pathways, there were no specialist teams in the health visitor, and there was no secondary care allergy team. And that really led me personally onto my journey in allergy, but I saw it firsthand the minute I joined community services. And I think there's no community services. It's an incredibly important issue because it impacts every community service across the whole country. Yes, that's when it first came on my radar.
Thank you, Anne. And like most of you have mentioned, CMPA affects 3 to 5% of children in the UK, making it the most common food allergy in young children. Yet it's often misunderstood. So, Christian, what is the biggest misconception you encounter about CMPA, and why do you think it persists in policy and public conversations?
The biggest misconception we've seen through our advocacy in particular is a fundamental misunderstanding of the difference between lactose intolerance and cow's milk protein allergy. In 2017, Allergy UK were deeply concerned that we found out that clinical commissioning groups, the precursors to integrated care boards, had consulted on proposals to remove specialist hypoallergenic infant formulas. We discovered that the reason these formulas had been proposed for deprescribing was a misunderstanding of the difference between lactose intolerance and cow's milk protein allergy, as well as misunderstandings on the risks associated with providing alternate milks. Allergy UK raised our voice to this alongside the British Dietetic Association and the British Society for Allergy and Clinical Immunology. And we actively engaged with some of the consulting CCGs to raise our serious concerns. We also spoke and provided a written letter to the Minister of Public Health and Primary Care, Steve Bryan MP. But based on a freedom of information request we submitted at the time, we learned that nearly 40 more clinical commissioning groups had planned to review prescribing infant formulas, and 43 more chose not to reply to our freedom of information request. The difference between cow's milk protein allergy and lactose intolerance matters deeply, because cow's milk protein allergy can affect infants in their first year of life and may require specialist management, where primary lactose intolerance is relatively uncommon in young infants, a misunderstanding that leads to inappropriate commissioning of services and the deprescription of specialist formulas, which makes access to vital medicines for those living with cow's milk protein allergy a lottery. Fundamentally, that level of misunderstanding at the head of the system has knock-on effects and repercussions all the way down, deepening the health inequalities we're seeing. As to why it persists, well, that really goes to the heart of the conversation we're having today about the way the system is structured, who's responsible for these issues, and just how commissioning is commissioned appropriately or otherwise.
And Anne, does this match what you see in your work? Are there other misconceptions that create barriers for families trying to access timely community-based allergy support?
Absolutely. As Nick described, cow's milk protein allergy is complex. The management varies from patient to patient, and I think there's an enormous amount of misperception. That's also what we hear when we get phone calls from our helpline. The common misperceptions, I think, is once a patient is diagnosed with it, that's it, that's sort of job done. But actually that's the very start, and they require specialist, complex, individual management in terms of what they can eat and dietary advice. One of the misperceptions that I came up against when I was in clinical practice is investment in allergy services is going to lead to overdiagnosis or overprescribing. And when we set up a community allergy clinic model in London, we actually found it reduced inappropriate prescribing and reduced diagnosis. There's some misperceptions around investment in allergy services, and I think there is confusion around prescribing and management, and it is very complex. The pathways and management plans across the UK vary depending on where you live. And I think that also feeds into some of the misperceptions, and also highlights the need for investment in specialist roles that can be those source and point of contacts.
And Nick, coming to you, what do these misconceptions look like in the consultation room?
Yes, I think, the biggest issue is that, as I've already said, Cambridge actually doesn't really present very clearly, particularly if it's that delayed non-IgE type. And Christian's obviously hit upon one of the issues, which is lactose intolerance confusion with cow's milk protein allergy, which means that, these young infants are often put on the wrong milks, the symptoms continue, and, they're left in distress for a longer period of time. And what we often see again, if it's IgE mediated allergy, so that, I've, had some milk for the first time, lips swelled, eyes swelled, hives, easy, most people will get, okay, that definitely looks like an allergy. But what we often see in clinic, and interestingly, the European data shows that actually non-IgE mediated allergy is more common than IgE. And what that means is we see babies with reflux type symptoms, colic, eczema, poor sleep, and all things that also occur in children without cow's milk protein allergy. So it's trying to work out what is sort of a normal range of those conditions and what might be driven by cow's milk protein allergy. And there are sort of signs to that, but again, you have to have been educated either undergrad or postgrad level about allergy, about cow's milk protein allergy, and therefore be able to recognize that pattern. And because those symptoms are often looked at in isolation, those patterns are missed. That's the big thing. And like I said, there's that confusion between non-IgE and IgE. And probably in the last few years, there's been a lot of concern about overdiagnosis, where any unsettled baby or any baby with colic, or got eczema is assumed to have cow's milk protein allergy. So what you end up having is families bouncing between reassurance or over intervention and without a clear diagnosis. I mean, just this week, a couple of days ago, I had a baby who's 2 months old and has had 8 changes of feed so far. They've seen different health professionals. One said, oh, try, goat's milk. One said, try a different cow's milk formula. Another one said, oh, why don't you go to your GP and get a specialist formula? The GP gave a specialist formula, but that didn't work. So then they were told to go back onto a cow's milk formula. So, depending on who they see, they're completely different advice. So what cow's milk protein does, I suppose, is almost hide, and it can look like a normal childhood condition until you join the dots.
And one of the major issues highlighted in the roundtable and then the subsequent report is that delayed diagnosis, like you mentioned, Nick. So Anne, just coming to you from your side, what does that delay kind of really mean for referrals, waiting times, and the ability to provide prompt assessment, diagnosis, and management in the community?
I think that was one of the major issues highlighted throughout the report, because, we've said the importance of getting the diagnosis because of the impact it has not just on the child or the infant, but the whole family. And I suppose for families, delayed diagnosis isn't just about time. It's the whole experience they go through, just like the child I've just talked about. They've had typical multiple healthcare contacts. They're often seeing different clinicians. They're trying different things, changing formulas, adjusting feeding, trialing medications. And all this time, the baby remains symptomatic. They're unsettled, they're not feeding well, they're not sleeping. The parents are exhausted and they don't feel fully heard, particularly, with the way sort of appointments are now, within the NHS. Certainly seeing your GP might be difficult. They might be seen online. The full sort of impact of the symptoms are sometimes difficult to get online. And even then when they're seen, they've only got a very short period of time. And actually sometimes that period of time isn't enough to talk about the impact that the symptoms are having. So what happens over time is that they lose confidence both in the system, their own instincts, and by the time they reach the right diagnosis, they've often feel they've done all the work themselves. I think it was Allergy UK. I'm pretty sure that there was a study showing that a lot of those patients have Googled the symptoms and worked out themselves that actually this is what's going on. So delayed diagnosis is a clinical issue, but it's also a real quality of experience issue for families and sort of losing that trust in the healthcare system. And currently what's happening, I suppose, is the journey that the families navigate, they navigate largely on their own without adequate, proper support.
Thank you. And Anand, coming to you, from your side, what does that delay really mean in the community?
No, I mean, just very similar to what Nick's described. So I think we can't underestimate the importance of trust in the relationship with the parent. And I think the longer the delay, what you typically see in the clinic room is the longer that patient has taken to get into your clinic room, the more time in clinic you have to take to explain, reassure, gain their trust. Also have to spend more time dispelling misinformation. And I think now, health being a huge area where it's one of the largest areas where there's misinformation online, you have parents that are desperate, that have high anxiety levels, and due to the variation in information that they've had from some healthcare professionals and online, their trust, it really takes a lot of work to get their trust, and that is a relationship that you're going to hold with them as parents for the duration of their child's childhood, so for 18 years. It's really critical. That delay, I think we can't underestimate the impact of that delay on their journey through healthcare services and also the outcome measures for the patient. And I think system-wise, we know there's lots of different initiatives across the country trying to address the problem, because the delay has an impact on systems. It has increased A&E attendances. There's lots of different research showing how many times someone sees a GP. Health visitors don't know who and when to refer to. There's barriers for health visitors in terms of how they can get access to specialist dietitians. So I think that delay has a system-wide impact, but also a lifetime impact potentially for that family.
Absolutely. And just talking about systems, Christian, if we come to you and zoom out again a bit more, what does that delayed diagnosis tell us about the wider system and what could be done differently?
Well, it shows us quite simply the wider system is struggling to keep up. Building off what Nick and Anne have been saying, we conducted at Allergy UK a survey of 2,500 parents of children with cow's milk protein allergy in 2017. And we found that on average, parents visited their GP 5 times before they were diagnosed. But just 29% of cases were diagnosed by GPs, with the remainder diagnosed in secondary care. Allergies are overburdening GP appointments, and GPs, many of whom who don't have the training or knowledge of allergies, are being asked to make diagnosis and referrals. Currently, 8% of all GP appointments are allergy related, but without a centralized understanding of allergy prevalence, diagnosis and existing pathways, primary care is ill-equipped to manage this volume. And when these patients are going on to secondary care, then this issue is being passed down the chain. It's overburdening hospitals. It's creating unnecessary appointments. It's placing a burden on the system. The current NHS allergy specialist workforce is failing to meet patient needs. There are only about 40 adult allergist consultants available nationally to serve the over 10 million estimated adult allergy sufferers, which amounts to roughly 1 allergy consultant per 250,000 people. I'd put that in context by saying the World Health Organization's recommendation is 1 allergist per 50,000 people. The system is, put bluntly, struggling. There are signs of this throughout.
Thank you, Christian. We've identified several challenges in the report, including inconsistent pathways, workforce gaps, variations in advice, and a lack of national standards. Christian, do you think these challenges are specific to CMPA, or do they reflect wider issues in allergy and even the broader systems? Where do you see opportunities for effective policy advocacy in the current political environment?
These challenges are certainly not specific to cow's milk protein allergy. We see these same issues reflected in allergy care across the board. We regularly conduct freedom of information requests to gather information. And in 2025, our findings from a freedom of information request to the ICBs, the 42 of England, were stark, and they reflected the issues we've been talking about. We found that 45% of ICBs view data on patients with allergies as a GP or hospital trust responsibility, rather than being the responsibility of the ICB. But we also know from the government's own files, publications, reports, that they consider ICBs to be responsible for designing and commissioning services tailored to the needs of their population. When we asked for data on the number of patients diagnosed with an allergy, only 9 or 21% of ICBs could give us a response. And not one ICB held data on whether there were any specialist allergy nurses or dietitians within their region. This was the same answer we got in 2023. We'd had no variation in answer across 2 years, despite supposed reform in this area. However, politically, there is an issue here. We submitted a written question to the government's health minister last year, and Baroness Merron, responding, told us that NHS England doesn't collect national data on allergy prevalence or services, and it doesn't issue specific guidance, but in conducting health need assessments to inform their commissioning decisions, integrated care boards have access to a wide range of data sources, including public health data, hospital statistics, primary care data, and social care metrics. There is a gap between what the government believes to be the case and what ICBs are experiencing on the ground, and it's in that gap that these issues are arising. Some integrated care boards we spoke to couldn't agree on whose responsibility allergy was, let alone giving us an answer. But there are silver linings, there are moments of opportunity. The 10-year health plan for England represents a once-in-a-generation chance for better. And in particular, we were delighted on the 1st of June when it was announced by the Health Secretary, James Murray, that allergies are going to be included in the single patient record, that there is an opportunity that the government is committed to including allergy data as a centralised form for all patients within the NHS. Allergy healthcare shows huge potential to demonstrate a shift towards prevention, and demonstrating that alignment is an absolute priority for Allergy UK and should be a priority for everyone advocating in this system. What we're calling for is what the government is calling for. It remains on us to demonstrate that.
Thank you. And coming to you, do you see these types of challenges? Do they show up also across other conditions?
Yeah, so I think, but again, building on what Christian said, we talked about in the report about inconsistent pathways, workforce gaps, variations in advice, and a lack of national standards. And really, what we see in cow's milk protein allergy is very much a reflection of the wider allergy system and diagnostic process. And certainly, what we see is the same themes coming up again and again. We see fragmented pathways, we see variation in practice, and limited access to specialist expertise. Again, because the number of allergists, as Christian has just highlighted, are much lower in the UK than they are elsewhere according to the amount of population. And I suppose the other thing, obviously, again, that's been pulled out is that there's no real clear ownership of the patient journey. Is it primary care and the GP? Is it the paediatric department? Is it specialist allergy service? Is it the dietetic team? That lack of clarity then leads to delays. Certainly, we have referrals that go to one specialist, but they say, well, we can't see them until they've seen this specialist. Then it comes to that specialist says, well, actually, it's not in our area. You have to go to your local hospital. So you can see all those little touch points then lead to further delays because there's that lack of clarity. And then you add workforce pressures in. So obviously we know that at the moment the workforce is quite depleted, and therefore people who are already in the sort of system are trying to have to work harder. They can't keep up with the demand. And then you've got those few specialists, but then the others who could help, for example, in primary care services, there's a variation in training. So they might not know about allergies, they understand the nuances of allergy. And therefore it becomes really hard then to deliver consistent, good, consistent care. So I suppose in many ways, cow's milk protein allergy is a really good lens through which to understand the broader challenges in allergy services. And I think it fits really, really well with the government's prevention agenda, because if we take it just for example, peanut, we know that early peanut introduction prevents peanut allergy, and certainly in the US they've implemented a policy where this is recommended, and they've already started seeing a decline in individuals with peanut allergy. So it shows you that population level prevention strategy does work, and in the longer term will actually save you money, and more importantly, will prevent people having allergy and being at risk for the rest of their lives of anaphylaxis. So I have to say, cow's milk protein allergy is certainly not an exception. I think it's an example.
And now coming to you, just you feel that improving CMPA care as a blueprint can fix other pathways and demands?
Yes, absolutely. Just as Nick has described, we see the same pattern with eczema, immediate food allergies, asthma, GPs unsure how to manage, for example, a food allergy, what to test for, how to interpret the management advice to give. Eczema and asthma, multiple A&E appointments. And there's data out there showing if you do interventions in the community for asthma and eczema, is significant, that those patients should not be presenting to A&E. So that in itself highlights the problem. I think the solutions, just as Nick said about talking about the lens, I think the solutions to improving management in the community of cow's milk protein allergy is a blueprint, and it can translate across all of the allergic conditions. And I really believe, and I know at Allergy UK we have a policy call, if you have a local specialist allergy dietitian and a local specialist allergy nurse that knows the community, the systems, the pathways, can remove some of those barriers. If we get it right for cow's milk protein allergy, that has a direct knock-on effect on the other allergic conditions, on the healthcare professionals that are supporting those families with education and advice, and also on the outcomes of that patient, because we know cow's milk protein allergy goes hand in hand often with severe eczema. We know if we don't treat the eczema well, there is a higher risk of having other allergic conditions and food allergies. So it's critical. It's so important. And I think the cost effectiveness and efficiencies and improvement to systems, again, is lifelong. So just as Nick and Christian have said, it's that window of opportunity of getting it right. And the impact, the knock-on impact, doesn't just cover cow's milk protein allergy. It covers all of the allergic conditions.
And inequalities came up quite strongly on the round table, both geographically and socioeconomically. Given like the diversity in areas like Birmingham, Nick, where you work, where do you see the biggest disparities across the different communities?
Yeah, so I think inequalities comes through very strongly, and that's throughout the whole healthcare system, not just allergy. And that's why I suppose the government have taken a stance on we must tackle this, because actually, good health should be available and accessible for all, not just parts of the population. And as for in a place like Birmingham, you can really see those inequalities play out. I mean, there's some historical studies from Birmingham where we've shown that if you're a non-white patient, you're at a higher risk of having an anaphylactic episode. Now, is that because biologically you're more at risk, or is that because you not have the education that you should have had in a clinic, for example? You're more likely to have adrenaline prescribed after anaphylaxis and more likely to get referred to an allergy clinic if you're non-white. Sorry, if you're white than if you're non-white. So again, there's that discrepancy, that bias creeping in. When we see patients in our clinics, we get a set amount of time. So each new patient for me is sort of 20 minutes. Now, if you've got a patient who doesn't speak English, how do you get the same information from that patient? How do you give information to that patient if you've only got that same amount of time? You need an interpreter. You might need to have to ring language line to get further information. Now, if you've got, and often I have 2 or 3 patients in a clinic like that, where it's great if someone's let me know beforehand that this patient might need an interpreter. Then we have an interpreter there, but that takes time. But often no one's told us, so they come along, they don't speak English, and then it's very difficult to get a truly representative story from that patient. So there's that whole sort of what goes on in the clinic, and there's differences in how quickly families can access care, and how easy it's to navigate the system, and how confident they are in engaging with services. So again, the BRIT, which is a national allergy database, found that if you're from an affluent area, or if you are white, you're more likely to be referred directly to a tertiary centre who offers immunotherapy than if you are from a deprived area or in an ethnic group. Then you have to go through a number of hoops before you get your final referral. So again, showing that sort of bias that goes on in the whole healthcare system. So, language and health literacy are the big factors. Hopefully you can understand that now, and understanding symptoms, knowing when to seek help, and being able to advocate for your child. We know that, again, Asian mums are more likely to seek advice from their family members than go to the doctor because of historical trust issues and things like that. So the socioeconomic sort of factors matter. And remember, unfortunately at the moment, certainly with allergy, we still ideally want to see that patient face to face. We can't do sort of testing and stuff online, but that means time off work. And remember, some families, won't get, some families don't get paid if the main breadwinner doesn't go to work. Some of us are lucky, if we go to an appointment, we still get paid. A lot of these don't. Therefore, that makes a cost pressure, and it makes it difficult to attend multiple appointments. So certainly, if we think of something like immunotherapy, for example, which needs 2 weekly updosing to, increase the amount of allergen you're giving. It will make a big difference to whether that patient can come or not and have access to that treatment. And then sort of there's geography as well. So access to dietitians, specialist service can vary quite dramatically depending on where you live. So it's not just really one thing. I think it's layered across the whole pathway. And as with all healthcare, there's the inverse care law, isn't there? The families who need the most support often have the hardest journey to get through the system.
Thank you. And Christian, nationally, what structural factors are driving these inequalities, and how do they intersect with prevention, digital priorities in the 10-year plan?
So, one of the biggest structural factors driving these inequalities is the lack of a clear national framework for allergy. Because it's uncertain who should be commissioning these, ICBs are often left to develop their own policies, even their own management. I mentioned that previously, but it can't be emphasized enough that if there is no strict guidelines on what should be done, ICBs will fall through the cracks. And we know of entire regions that don't have commissioned allergy services, where the people living there are forced to commute long distances to access the services that exist on other people's doorsteps. Those people might not have the wherewithal to travel for hours to get to the south, where many of the allergy services are. And on top of that as well, we have to talk about the data issue. The lack of joined up data causes so many issues. Building off what Nick was talking about, the 20 minutes face-to-face with patients, well, I'd ask Nick how much of that time is spent getting them to give a history of their allergy when it first presented, what it is, what they think it is, the people they've seen previously, because in many cases, records are not shared between GPs. And we see many cases, some of them sadly fatal, where people with a known allergy who then travel outside of their GP's catchment area, they might travel to university if they're young, they end up in hospital where their records are not transferred, and they're given food, they're given medicines that they have a known allergy to and react to it. My wife is a surgeon and has seen patients in hospital recovering for an operation given food they are allergic to, which you would assume a hospital would be the safest place in the world. But no, because the data isn't there. It's a structural factor that drives inequality throughout. Further to this as well, and further to the issues of ownership, is the fact that in many cases where issues and inequalities are identified, the groups that are creating best practice don't believe it is their place to comment on it or to even really acknowledge it. Just over 2 weeks ago now, the National Institute for Health and Care Excellence, NICE, produced an updated guidance sheet on anaphylaxis regarding assessment and referral after emergency treatment. They put in their recommendations. After emergency treatment for suspected anaphylaxis, the patient be recommended to a specialist allergy service consisting of healthcare professionals with the skill and competencies necessary to accurately investigate, diagnose, monitor, and provide ongoing management of and patient education about anaphylaxis. This feels fairly straightforward. Similarly, they've identified that each hospital trust providing emergency management for suspected anaphylaxis should have separate referral pathways for suspected anaphylaxis in adults and young people and children. Now, the stakeholders consulted on this raised a concern about health inequalities. They noted, or the College of General Dentistry and the Association of Pediatric Emergency Medicine, both noted that there are concerns over a patient's ability to access specialist allergy services, with the Association of Pediatric Emergency Medicine straightforwardly saying that access to allergy clinics for poorer resourced areas were a concern of theirs. But responding to this, NICE replied, These are operational issues outside of NICE's remit, which is to make evidence-based recommendations to ensure quality of care. Functionally, that it wasn't their responsibility to develop these clinics, or even really to identify this as an issue, that this was best practice for hospitals to follow. It's a concern that goes throughout and develops these inequalities that we see. Best practice recommendations are rooted in services that don't exist. ICBs responsible for commissioning healthcare don't have data to base planning decisions upon, and patients are left at the mercy of a system unable to recognise, let alone cope with the scale of the issue. I would note once again that there is a glimmer of hope that prevention and digital priorities in the 10-year health plan do offer opportunities, and integrating allergy data into the single patient record will allow the scale of the issue to be identified. It will provide the data that provides the foundation for the commissioning, and ideally that would identify the inequalities that we all see. But there is so much more to be done.
And on that, what could be done? What do you think could be some of the solutions on the ground for patients and parents?
No, I think what we have in the UK is pockets of really phenomenal initiatives, which by default sometimes can create postcode lottery again. But there are areas in the UK that have invested in outstanding local allergy advice and support. For example, investing in expert health visitors, dietitians, and nurse specialists in every ICB that is a point of contact and connected to all of the other healthcare professionals that acts as a conduit to remove barriers. I think if we had a platform to be able to showcase where it works well nationally to do learning, I think these services are stretched. They're working on goodwill and they are demonstrating good and positive outcomes, but there is nowhere for them to share it in a platform that is really going to support investment in other services. When we set up the community service, a one-stop shop, what we found worked really well was we insisted that health visitors could refer directly to the community allergy clinic that was run by a GP with a specialist interest, an allergy nurse specialist, and a dietitian. We met a lot of resistance about that because there was anxiety that we would be flooded with inappropriate referrals and we wouldn't be able to sustain the clinic. The reality was we weren't. We were appropriately contacted. It led to education and opportunity advices. It built relationships with healthcare professionals, and it avoided that pattern that we often see, which is the health visitors worried. They go to the GP, they tell the patient to go to the GP, and this patient bounces between services. So I think learning from services that have done it well, investing in every ICB having a specialist allergy dietitian particularly and nurse. This is a really exciting time. It's a sobering time when we look at the health inequality data. It's really sobering, and it's a sobering time when we look at the changes that are happening in the ICBs. But there's also the evolution of neighbourhood health and what that looks like. And the care closer to home is really exciting, and investment in services closer to home. And we have that data to show the importance. So I think it's investment in local allergy leads that will really make a difference to each community to be able to identify what they need and reduce delays.
Absolutely. Delays are incredibly important so that patients can be seen sooner. And on that, so if we were sitting here, say, in 12 months' time, what would need to have changed for you to say that this report had a genuine impact and difference? What success measures would you like to see in the real world? So if we go to you, Nick, in terms of clinical outcomes, what would be important for you to see in 12 months' time?
In 12 months, what would need to change? So if we're sitting here in 12 months' time, what I would probably want to see is earlier recognition. So fewer repeated consultations before a diagnosis is made. Christian's already said, the patient has to see the primary care service 5 times before someone makes a diagnosis. So I think we want to see that earlier recognition. What else would need to change? We'd have to have clearer, more consistent pathways that clinicians feel confident using. So obviously we have got pathways out there. At the moment, they're not being used. We have an IMAP guideline for primary care. We have the nice food allergy guidelines for primary care as well. And when I give talks to primary care, and I ask them, how many of you know there's a nice guideline? About 3 people put their hand up in a room of about 100. And if I ask them how many have read it, nobody has. So again, it's trying to make those pathways more embedded in that care. Access to dietetic support, especially in the community setting, that's going to be really key, because obviously we have access in secondary care, but actually what we need it is early in the community. And families would need to report, so we need to look at patient-related sort of experience measures, and they should be seeing a smoother experience and feeling heard, supported, and guided through that process. And I suppose from a system perspective, we'd be starting to see reduced variation. So as obviously Anne's already said, that whole postcode lottery going on, that should stop, because everybody's working to the same sort of guidance and processes. And I suppose, Cow's milk protein allergy needs to be recognised as a priority within early life prevention strategies, because we've said, at that early stage, it's not just that child that's affected, it is the bigger family unit. And obviously, if we take that to the nth degree, that has an economic impact ultimately. Investing will in the long term save money. So I think success really is families getting the right diagnosis early rather than after months of uncertainty.
And Christian, for you, what would you like to see changed in 12 months' time in terms of the policy movement?
Well, to be honest, I don't think we've got time to go through all the things I'd like to see changed, but to kind of bring it back to something I can discuss, positioning cow's milk protein allergy, as Nick has said, as an early intervention opportunity within the NHS prevention agenda and the early years policy. This is about as clear a case as you can get for early intervention making a lifelong lasting impact, reducing the impact on the NHS, and it can be handled in primary care if it's appropriately resourced. We know it, we've lived it, we can prove it. It's just about breaking through and showing this. That's the main thing from this report I would like to see done. Beyond that, we have the promise of allergy as an embedded data form within the single patient record. I want to see that come to fruition and not forgotten, embedded from day one, and that data used to showcase best practice, to raise up those areas that are doing this well, to ideally form a modern service framework for allergy as a whole, to showcase this is what we can do. The UK is well known internationally for coming up with best practice for allergy. We're just very poor at implementing it. And doing so, stepping forward and taking that step, that would be everything for us.
Thank you. And Anne, for you, what's one thing that you would like to see changed in 12 months' time?
I think success would be that the families get the right advice from the right person at their first point of contact without needing to navigate services themselves. That sounds ambitious. In the NHS, there's something called GIRFT, getting it right first time. Allergy doesn't feature on that list in the NHS England list. Other chronic long-term health conditions do. And I think it is spending time looking at how do we get it right at the first point of contact for the family. That would be one thing. As Nick has talked about tools, I think standardising tools and management is very confusing across the UK. And I think standardising and agreeing approaches would be useful for all clinicians, and investment and understanding that investment does equal cost savings. So all very ambitious, but in 12 months' time, if that's what we could see, that would be phenomenal.
I'd also be remiss if I didn't point out that recently we saw the publication of the UK's first national allergy strategy, which does implement and suggest implementation for government that covers cow's milk protein allergy. It covers the whole raft of measures developed by the whole community. So I'd be remiss if I didn't point out that is something that is a framework in the hands of government presently.
Thank you. And to Anne and Christian, you both attended the roundtable with Nick, and Nick, you closely worked with Global Policy Network, both on the roundtable and the report process. What stood out to you, each of you, most about GPN's approach in convening stakeholders and translating those discussions into concrete policy reports? If we come to you, Christian, first.
Absolutely. So I'd be keen to say that your approach to using professional experience and testing our experience and ideas against the wider evidence base and the current policy landscape, because that ensures that the recommendations we're making are fit for purpose, but that recognise the limitations and the opportunities we're working within. I've been privy to too many roundtables where we've come up with recommendations that just aren't going to fly under the current circumstances and the limitations the government is working within. So I think these roundtables matter because they're producing actionable results.
And Anne?
I think for me and for Allergy UK, it was a brilliant opportunity to hear about those pockets of outstanding practice and to hear what's working well. There was new information there that was shared by experts in their field on what they had done and how it had worked well and positively impacted the allergic community. That gave us at Allergy UK lots of ideas to go away with, and we're just exploring how as Allergy UK we can support rolling that out and amplifying that voice across the UK. It was excellent and outstanding to be able to hear some solutions and ideas from people who have successfully done it.
Thank you. And Nick?
Yeah, so I think it was the professionalism around setting this up in the first place, sort of thinking about, who should be around that table, who is involved in care of these patients, who can see what's happening, and that sort of depth of experience, really. So it was, the MDT approach as well. It wasn't just medics, wasn't just nurses. It was a really wide group of people, all of who have a sort of a point of contact within the whole pathway. It was really great, for example, having a pharmacist on that panel, because they brought a whole different level of sort of experience and views of what could be achieved if they were allowed to be part of the pathway in a more sort of integrated way. So I thought that was really good. And from my point of view, hearing the experience not only of the panel, but obviously there were people who were listening in, and it was great that like Anna said, there was people who talked about their poor experience and what they would like to do differently, but we're hearing those pockets of really good experience and trying to work out how we put that all together. So for me it was really sort of an outstanding example of multidisciplinary team discussions, which for me led to a really comprehensive and practical report that I think people will be able to read, understand, and more importantly think about how to implement it into real life practice.
Thank you. So Nick, Christian and Anne, thank you so much for joining us today and bringing such a thoughtful and grounded discussion. Today's conversation highlighted how calcic protein allergy is a system issue and that no single organisation can fix it alone. The report sets out clear direction, practical steps to improve pathways, reduce inequalities and give families the support they deserve. We encourage policymakers, commissioners and clinical leaders to read the report, share it with colleagues and use it to drive change locally and nationally. Thank you all for listening. Please give Global Policy Network a follow on your LinkedIn and Instagram, as well as our podcast on YouTube, Spotify and Apple Podcasts. Stay tuned for more episodes and the release of the report, and keep up to date by subscribing to our newsletter at globalpolicynetwork.com. Thank you and goodbye.